Thyroid Foundation. Thank you very much for joining this webinar tonight, which is being hosted jointly by the British Thyroid Foundation and the British Thyroid Association. The BTA is the organisation for professionals at all stages of their career who look after patients with thyroid disease, and many of whom carry out research into thyroid disease as well. The BTF works together with the BTA to ensure that patients have access to evidence-based information. We also support patients in various ways. For example, we have a medical query answering service, online forums, and a telephone helpline so that patients are in a better position to understand their diagnosis and to live better with thyroid disease. Just to let you know, this meeting will be recorded, and the recording will be added to the MIMS learning web platform for GPs in the next few days, we hope. And now, without any further from me, I'm very pleased to hand you over to Professor BJ Vaida, who's the Secretary of the BTA and is one of the chairs of this webinar.
Thank you, Julia. And good evening, everyone, and welcome to this first joint BTA-BTF seminar on hypothyroidism diagnosis and treatment. So as Julia said, I'm Vijay Vaide. I'm one of the endocrinologists in Exeter, and I'm delighted to co-chair this webinar with Sam Fenniken, who is an academic GP from Birmingham. We are really lucky to have two excellent speakers for this webinar, who will give short talks, and we'll have plenty of time for questions and answers. So do put in your questions in the Q&A chat boxes. We'd also like to hear your feedback on the webinar and any suggestions for future meetings. Now, I'm delighted to introduce first speaker, Dr. Nicola Jamet, who is a consultant endocrinologist at Edinburgh Royal Infirmary. She's also a member of the Executive Committee of British Thyroid Association and is one of the co-authors of the recently published BTA SFE consensus statement on T3. Dr. Jamet will talk on the diagnosis of hypothyroidism. Nicola.
Thank you very much, BJ. I'll just share my screen and put up my first slide. Oh, hang on. Sorry. There we go. Sorry, having this worked a second ago, and I'm having a bit of technical difficulties just now. Let me just try that again. Sorry about this. My slides just aren't moving forward. Just try that one more time.
Can you try in the bottom left-hand corner? Mine looked a bit strange this time too.
Right, does that look, can you see my first slide there now?
Yeah.
Great, right, sorry about the technical difficulties. Thank you, BJ, for the introduction. So for the next 20 minutes or so, I'm going to speak about the investigation of hypothyroidism, which, as you know, is a common problem affecting around 3% of the UK population, women more than men. And on the face of it, this should be fairly straightforward. We know the symptoms of thyroid disease, we have some blood tests to confirm it, and we have a treatment that we can give. And while many people do feel well once they're on daily levothyroxine, there is a significant proportion of people who don't feel well on this treatment. And we often focus a lot on the treatment itself of hypothyroidism and whether we should give something else in the treatment rather than just levothyroxine. But what I'd like to do over the next 20 minutes is really argue that a thorough and thoughtful investigation is necessary to underpin successful treatment of hypothyroidism. And I will, towards the end of my talk, refer to some aspects of this consensus document which refer to investigation. So we begin, as we always do, with a person in front of us with a range of symptoms, and those symptoms are probably going to be suggestive of an underactive thyroid. And I won't reiterate those symptoms, they're familiar to all of you, but what I will do is circle in red the ones that I could personally pick off most days of the week. Now, I know for a fact that my thyroid works normally, and so these symptoms really relate to factors to do with my lifestyle, my genetic makeup, and things that are really unrelated to thyroid disease. So it's really just to make the point that some of the symptoms that can be consistent with or are suggestive of thyroid disease do not confirm the presence of a thyroid disorder. We do need to do additional investigations to confirm that that's what the problem is. And there's no evidence to support treatment for people who have symptoms suggestive of thyroid disease if their thyroid function tests are completely normal. It's also important for us to understand the causes of hypothyroidism, because that will help guide us in our investigation as well. And in the UK, the majority of hypothyroidism is either caused by autoimmune disease, so Hashimoto's thyroiditis, or iatrogenic causes, so people who have previously had an overactive thyroid but have been treated with surgery or radioactive iodine. There are other causes, for example, some of them are temporary, such as viral thyroiditis or a postpartum thyroiditis. And it's important, therefore, to remember that just because somebody has abnormal thyroid function tests at the point in time where you're seeing them, it doesn't necessarily mean that their thyroid function will always be abnormal. And it's also worth being aware of the medications that people are on, because certain drugs such as lithium and amiodarone can also cause hypothyroidism. So in order to move on, we've seen someone, they've got symptoms suggestive of hypothyroidism, we want to investigate them. We need to understand what the different hormone levels mean. And so I'm going to just, for a couple of slides, refresh everybody's memory on some basic thyroid hormone physiology. We have in the top left of the screen the thyroid, which is under the control of the pituitary gland. The pituitary produces thyroid stimulating hormone, which docks in the TSH receptor, and that instructs the thyroid gland to make two thyroid hormones, T4 and T3. Now, the thyroid makes mostly T4 and a little bit of T3. Both of these hormones circulate in the blood. Both of them move into the cell, but it's only the T3 which moves into the nucleus and docks here with the thyroid hormone receptor. And T3 is basically the active hormone. It's the one that does all the work. T4 is really there as an available storage hormone, if you like. The analogy would be if I go to my kitchen, I've got fruit and vegetable that is in a readily eatable form to be used today, tomorrow, and the next day. That's my T3. And then I've got frozen food, canned food, dried food like pasta, which with a little bit of modification can be made ready to eat. That's like my T4. And so the beauty of that system is that it means that different tissues within the body can regulate the levels of T3, because not every organ in the body needs the same amount of T3 at the same time. Most of the T3 is not produced by the thyroid. Most of the T3 is converted peripherally using deiodinase enzymes, which remove one iodine from T4 to convert it into T3. And there is a suggestion that some people may perhaps not be as efficient at converting T4 to T3, and that's one of the arguments that are sometimes made in favor of giving combination therapy with T4 and T3. The other regulatory system that controls thyroid hormone production is what's known as the negative feedback loop. So we've already mentioned our pituitary gland, which makes TSH, and that stimulates the thyroid to make T4 and T3. But those hormones then feed back to the pituitary and indeed the hypothalamus. And what they do is they inhibit production of these hormones. So in other words, if your T4 and T3 get too high, then they switch off the production of TSH, and that in turn reduces the stimulation of the thyroid and reduces the amount of T3 and T4 being made. So under normal circumstances, we have a system that, like two children on a seesaw, should be perfectly balanced. But if one set of hormones, T3 and T4, goes up, the other one, TSH, goes down. So when we have an underactive thyroid and the thyroid is not making enough T4, that reduces the inhibition on the pituitary. The pituitary makes more TSH, which is really the hormonal equivalent of the pituitary shouting at the thyroid, telling it to work a little bit harder. So this is the pattern of hormones that we should see if somebody has barn door overt primary hypothyroidism, a low T4 and a high TSH. But of course, there are a number of variations on that theme. Yes, this is the barn door one that we see when somebody is definitely hypothyroid, and the TSH is usually significantly elevated, often above 10 milliunits per litre. But we'll often encounter this situation where the TSH can be raised, but the T4 can be normal, and we call that subclinical hypothyroidism. subclinical because the T4 levels are still normal, and therefore we don't necessarily think that people should experience symptoms when they have this condition. But the question, of course, is whether they might go on to develop overt hypothyroidism in the future, and I will come back to that in more detail shortly. I also want to mention secondary hypothyroidism, and this is really where the problem lies with the pituitary rather than the thyroid gland. So if you see this pattern of a low T4 and a TSH that fails to rise, then you should understand from what we've said about negative feedback loops that that's not normal. Something in the feedback loop is not working. And what that tells you is that the problem really arises with the pituitary. And in this situation, you definitely do not want to commence thyroid hormones until you've spoken to your friendly local endocrinologist, and we would check other hormones and potentially replace cortisol before we commence levothyroxine. So this is one situation to look out for where you definitely need to discuss with a local endocrinologist. And the other situation that I'll mention is what's known as non-thyroidal illness, which is basically where illness elsewhere in the body can cause disruption in thyroid hormone levels. So for example, if somebody's acutely unwell with a chest infection, we might find that their TSH and T3 might be low, but these are temporary abnormalities which will resolve when the underlying acute illness recovers. And so the basic message is don't check thyroid function tests in somebody who's acutely unwell if you don't think that they've got thyroid disease. So when somebody has clear evidence of hypothyroidism, we would still recommend repeating the thyroid function tests before you initiate treatment. And why is that? It's because actually thyroid function tests will sometimes normalize, and I'll show you some data later on to back up that statement. The situation that we previously mentioned, subclinical hypothyroidism, is a little bit more nuanced. We definitely want to repeat the thyroid function tests in this situation because around 50% of people with subclinical hypothyroidism will experience spontaneous normalization of thyroid function tests. We may also want to check the thyroid peroxidase or TPO antibodies because that will help us to understand what the risk is of the person with subclinical hypothyroidism going on to develop overt hypothyroidism. And this is a study which I often quote to patients when we're trying to decide together whether or not they want treatment for subclinical hypothyroidism. So this is the Wickham study, which began with an initial cross-sectional snapshot of thyroid disease across a mixed urban and rural population in the northeast of England, and then followed those people up for 20 years. And so what this study found was that if somebody had a raised TSH at the start of the study and they were followed up for 20 years, about 2.5% of those people developed hypothyroidism each year. And at the end of the 20-year follow-up, a third of them had hypothyroidism. But that still means that 2/3 of them with a raised TSH at the start didn't have hypothyroidism at the end of a 20-year follow-up. If we look at the people who had positive thyroid peroxidase antibodies, around 2% of them converted to hypothyroidism each year, and just over a quarter of them were hypothyroid at the 20-year mark, but nearly 3/4 of them still had normal thyroid function. And if you had the combination of high TSH and positive antibodies, it was just under 4.5% of that group per year that converted to hypothyroidism, and just over half who were hypothyroid at the end of the period of follow-up. Now, we know from a number of large randomized control trials that certainly in older patients with subclinical hypothyroidism, there's often no meaningful change in symptoms or quality of life with treatment. And so that really begs the question when and whether we should treat subclinical hypothyroidism. And usually we would suggest that if you have a persistent elevation of TSH, so above 10 on 2 occasions, and thyroid peroxidase antibodies are strongly positive, that you consider treatment. And I say consider with a couple of caveats. The first is to remind the person in front of you that even if they came to you with symptoms, it may be that the thyroid function tests do not account for those symptoms because by definition their T4 is still normal if they've got subclinical hypothyroidism. And the second is that they may not develop hypothyroidism for many years, and so some people may prefer not to commence medication and to adopt a watch and wait approach and continue to monitor thyroid function tests going forward. So ultimately, what we want is the person in front of us to end up feeling better, and that's probably what they want as well. And there are a number of reasons why they might not end up feeling well on levothyroxine, many of which are covered in this narrative review from Petros Peros and colleagues a couple of years ago. I'm not going to touch on the hypothesis of low tissue T3 because I've mentioned that already when we spoke about thyroid hormones, and that really is verging on treatment. But I'm going to just briefly touch on some of these other hypotheses because they relate to how we might investigate somebody with hypothyroidism. So one suggestion why people might not feel well on levothyroxine is that it's not just the thyroid hormone levels that contribute to symptoms, but it's the underlying process of autoimmune damage or neuroinflammation. And we've said that really autoimmune causes are one of the most common causes of hypothyroidism in the UK. Now, there are some observational studies that show that patients with positive thyroid antibodies had more symptoms, poorer quality of life, and more anxiety and depression than controls, but not all studies show this association. And specifically, the largest observational study of around 30,000 people did not confirm this association. There was one study which actually randomized people with previous thyroiditis and persistent symptoms, but normal TSH and high thyroid peroxidase antibodies to either thyroidectomy or no treatment. A slightly brave study, perhaps, because essentially what you're doing is you're taking out a thyroid gland in somebody with normal thyroid function tests and consigning them to lifelong thyroid hormone replacement. But there you go. The surgical patients did have a fall in thyroid peroxidase antibodies, which is perhaps not surprising because you've taken out the big chunky tissue that is stimulating the immune system to make antibodies. And that group did experience greater improvements in general health and fatigue scores. But these are all subjective measurements, and the difficulty is that there wasn't really a proper control arm. In order to do this study scientifically in a robust way, you would need a sham surgery arm where you gave the other people a general anesthetic, a scar, but did not remove their thyroid, and that's an ethically sticky thing to do. So it's an interesting hypothesis that the antibodies and the autoimmunity might be the cause of the symptoms, but there's certainly no confirmation. So what does that tell us about thyroid peroxidase antibodies? Well, you might want to measure them to confirm that the cause of hypothyroidism is autoimmune. And I would argue that they are very useful to be measured in somebody with subclinical hypothyroidism, because it will help you understand the risk of that person developing hypothyroidism in the long run. But there's definitely no role for serial testing. And at present, there's no treatment that will actually tackle the underlying autoimmune process. The next two hypotheses are slightly related in that really both of them are suggesting that we need to cast our investigative nets more broadly than just the thyroid and think about other conditions that might impact on people's health. So somatic symptoms and related disorders really refers to persistent bodily symptoms associated with functional impairment. So things, for example, like irritable bowel syndrome, which can cause a high degree of symptoms and morbidity and are very common in patients in primary care. And similarly, we can have people with other comorbidities that are not functional, for example, COPD. So if you have somebody who feels very tired because they're short of breath and their COPD is not well controlled, then no amount of adjustment of thyroid hormone replacement is going to make them feel better. So although this talk is really about investigation of hypothyroidism, I would argue that as doctors who ultimately want to make the person in front of us feel better, we need to remove our diagnostic blinkers and think not just about the thyroid function tests, but about the wider context of health and psychosocial circumstances for that person in front of us, because some of these may be impacting on their health, and clearly symptoms that are not caused by hypothyroidism won't be alleviated by thyroid hormone replacement. So if we're saying that we should definitely make sure that people are properly hypothyroid before we begin treatment, how good are we at doing that? Well, it turns out that we're probably not very good. There are other studies from the UK that show similar findings to this one, but I think this is quite impactful. This was published in the Journal of the American Medical Association a couple of years ago, and it was a retrospective analysis of more than 110,000 people who commenced levothyroxine over a 10-year period. And I'd like to draw your attention to the TSH level at initiation, which was 5.8 milliunits per litre in 2008 and 5.3 milliunits per litre by 2018. So when I've been saying to you that barn door hypothyroidism is often associated with a TSH of greater than 10, clearly levothyroxine is being initiated at lower TSH levels in the USA and also in the UK. And that TSH threshold seems to be coming down as time goes by. There was a subset of nearly 59,000 patients where full thyroid function tests were available, and when this was analysed, here were the findings. They're quite interesting. In 30% of people who were commenced on levothyroxine, they actually had completely normal thyroid function tests at the beginning. So arguably, these people might not have needed to be on levothyroxine. And if they were feeling that whatever symptoms were troubling them were not improved by levothyroxine, that might be because their symptoms were never caused by thyroid disease in the first place, given that we don't have objective evidence of hypothyroidism on their bloods. This graph really demonstrates that graphically, and it's showing you from 2008 to 2018, the dark band at the bottom, which is people with overt hypothyroidism commenced on levothyroxine. The middle bands are people with varying degrees of subclinical hypothyroidism, and this top light band is the significant proportion that are being treated despite having normal thyroid function tests. Now, perhaps the doctors who initiated levothyroxine were just more savvy than me. Perhaps they could see the way the wind was blowing and they could tell that these people were going to develop hypothyroidism and just got in sort of ahead of the game. Well, if that was the case, if we discontinued the levothyroxine, presumably we would find that they were now all hypothyroid. So what happens if we do that? Well, this study in thyroid a couple of years ago was a meta-analysis and systematic review of 17 studies which just addressed that exact question. So in total, there were 1,100 patients, most of them women. And interestingly, 37% of these patients remained euthyroid, so had totally normal thyroid function tests after their thyroid hormone replacement was discontinued. And again, if I show you that graphically, there were some studies that included children and adolescents, but the ones including adults alone, it was around 37% of people who remained euthyroid after thyroid hormones were withdrawn. The bottom bit of the graph is interesting because if you had overt hypothyroidism in the study that was looked at, then you had a much lower chance of thyroid function tests reverting to normal, roughly about 10% on average. If you had subclinical hypothyroidism, then you had a higher chance of your thyroid function tests normalizing when treatment was withdrawn, more like 35%. And in studies where hypothyroidism was mixed or not described, the rates of normalization of thyroid function when treatment was discontinued was close to 50%. So what I think this tells us is that if we robustly investigate hypothyroidism, we're more likely to get the treatment right because people are less likely to have normalization of thyroid function if we discontinue it. And I think this really emphasizes the importance of making sure that the diagnosis is robust. Now, of course, we investigate people at the start when we're trying to make a diagnosis, but we might also need to investigate people at other stages of their patient journey. For example, if they come and see us and are not feeling well on treatment or their blood tests are abnormal on treatment. And the last few slides, which I'm going to show you, come from the consensus statement on T3 produced by the Society for Endocrinology and British Thyroid Association. And this box looks at causes of persistently elevated TSH despite apparently adequate levothyroxine replacement. And so you'll remember from those feedback loops, if the TSH is high, it means that the pituitary feels that there's insufficient thyroid hormone in the system. And that can be for a number of reasons. It might simply be that we haven't given enough levothyroxine and we need to increase the dose. Or it could be that the person is struggling to take their medication. And if people are interested in question time, we can discuss how we might approach that issue of medication concordance, things like weekly supervised administration of levothyroxine or thyroxine absorption tests. But much more simple things that we can all look at, asking the person in front of us whether they're taking over-the-counter supplements such as iron or calcium, which can affect absorption of levothyroxine, thinking about whether we're prescribing anything that might affect absorption, such as proton pump inhibitors, and again, casting our investigative net a little bit wider and thinking about whether there might be any evidence of malabsorption that might mean that they're not getting the full benefit of their thyroid hormone replacement. We also want to think about whether there are any factors that mean that they might now need more thyroid hormone than they did before. We're all familiar with the concept of increasing levothyroxine at the start of pregnancy because high estrogen levels will affect the availability of free thyroid hormone. But we're maybe not so good at thinking about that when we commence people on the combined oral contraceptive or on HRT. So I've spoken a lot about not attributing symptoms of about making sure that we're not sort of blaming the thyroid for symptoms that might be attributed to something else. But the reverse is also true. It would be a real shame if you had somebody with hypothyroidism and you attributed their symptoms to the menopause, when perhaps what is really happening is that you put them on HRT. It's increased their levothyroxine requirements, but you've not increased the dose, and they simply need a bigger dose of levothyroxine. When we're looking at doses of levothyroxine, we often roughly judge this based on a patient's weight. So if somebody's gained weight, they might also need more levothyroxine. And if we've commenced them on medication, which will increase the metabolism and the breakdown of levothyroxine, such as anti-epileptics, then we might also need to increase their dose of levothyroxine. The T3 consensus proposes an algorithm for investigation and treatment, and I'm just really going to focus on the top bit of this, which deals with investigation. And it reiterates much of what I've said already, which is really making sure that the diagnosis of hypothyroidism is robust with repeat thyroid function tests and a significantly elevated TSH. It also touches on the idea that thyroid function tests can normalize, as I've shown you in that study, and considering a trial of withdrawal of T4. But importantly, again, thinking about casting that investigative net a little bit wider, it encourages us to think about other comorbidities. And so if your patient has autoimmune thyroid disease, they may have other autoimmune conditions, for example, celiac disease, and I would often be doing a synaxin test in clinic. We've touched on menopause, and other factors such as nutritional deficiencies, sleep apnea, and mood disturbance would be relevant to consider. So to wrap up what I've said, I think I've hopefully got across the importance of ensuring that the diagnosis of hypothyroidism is robust, the importance of repeating thyroid function tests because abnormalities can be transient. Checking thyroid peroxidase antibodies can help, especially with subclinical hypothyroidism, but it's a one-off test, not to be repeated. And if thyroid function tests are not barn door hypothyroid, do think about whether symptoms might be caused by something else and just cast your net a little bit wider. I think we're going to move on to the second talk and take questions at the end, but I'll be very happy to take any questions later on.
Thank you very much for that, Nicola. I've made a load of notes there. That was really interesting, and I learned a lot, actually. And I've got a few questions myself. But before we do that, we're going to move on to Professor Simon Pearce, who's another consultant endocrinologist working up in Newcastle, though I understand you're not in Newcastle at the minute, and also an academic at the University of Newcastle. So, yeah, over to you. Thanks, Simon.
Okay, well, thanks for such a brilliant talk, Nicola. That covers a lot of the issues we need to address here. So I'm going to really focus on treatment now. Here we go. So yeah, so the content I'm just going to talk about starting treatment, monitoring treatment, and one approach to patients with persistent symptoms on treatment. So this is easy, and we all do a lot of this. The treatment of hypothyroidism, once you've confirmed the diagnosis is persistent and that it warrants treatment, it is for the majority of patients is a full replacement dose of levothyroxine. And the next slide shows how to do a full replacement dose. And the exception to that is really three groups of patients, and they're people who are at risk of ischemic heart disease effectively. And that's because you can have long-standing hypothyroidism and you're batting along at a pulse rate of 50 for 10 years. And then you get started on levothyroxine and your pulse becomes 80 in 10 days later. And that's put a big increased workload on your heart, and that risks having an MI or worsening angina. And also in patients who've got known ischemic heart disease or tachyarrhythmias, atrial fibrillation. So, and people also with a very high TSH, in other words, if the TSH is 100, it tells you they've been hypothyroid for a long time and that you probably ought to go cautiously. But for most younger people, just a full replacement dose for these people, use your judgment, but titrate up from 25 micrograms daily or 50 micrograms daily in 2 to 4 weekly increments. And if they've got angina, I would be monitoring them just to say, just let me know that you haven't had an exacerbation of your angina or shortness of breath or cardiac symptoms before you increase the dose. And of course, the rapidity of the increase will depend on your suspicion of risk. You know, if they're just an old person, they haven't had any cardiac issues, then you could probably do it quicker than if they've got a recent acute coronary event or uncontrolled atrial fibrillation. So it's a dose-related dosing for levothyroxine, and the formula is kind of annoyingly 1.6 micrograms per kilogram per day. So if you're 50 kilogram, sorry, I can't see that now because the thing is in the way of my slide. If you're 50 kilogram person, the dose will be 75 micrograms daily, 60 milligrams, 100 micrograms daily, 75 kilos, 125. What that means in practice is, unless you're dealing with a really small woman, less than 45 kilos, you should probably start 75 or 100 micrograms daily in a woman. And for a man, you should start at least 125 micrograms daily if you're going to start on a full replacement dose. Do remember that TSH may take 3 to 6 months to normalize. The patient's likely to have been hypothyroidism for years, hypothyroid for years, and so that leads to pituitary thyrotroph hyperplasia, and the TSH coming down slowly just reflects those thyrotrophs involuting. So as long as the free T4 is in the reference range 8 weeks or 12 weeks after starting treatment, that's sufficient, and if the TSH is coming down, that's fine. So poor compliance is definitely an issue with levothyroxine, and I think probably poor compliance is an issue with every single medication we ever prescribe to any patient. The only main difference is we know people aren't taking the thyroxine because we can measure it pretty much directly in their bloodstream, whereas for very few other medications do we have that luxury of being able to find out whether someone's actually got it in their blood or not. But there are a few tricks. A few drugs prevent levothyroxine absorption. That's calcium salts, iron salts, and you need some acid in your stomach to dissolve the thyroxine. So proton pump inhibitors and antacids solubilize it to make it absorbable. And occasional people have true malabsorption, particularly celiac disease, but people with short bowel syndrome, they're going to know already. Also, people who've had bariatric surgery, particularly gastric bypass, they can end up on quite big doses of levothyroxine, and the absorption can be quite erratic in those cases. So that can manifest as a clinical problem that you have to seem to be rapidly changing the doses. So as well, when you start someone on levothyroxine for hypothyroidism, you're starting them on a condition for the rest of their life. So you do need to give an information prescription. So, you get this situation where the patient presents with tiredness, TSH is high, you do a prescription for levothyroxine, leave it with the receptionist who rings the patient, says, oh, there's a prescription for you to pick up. And then the patient takes the tablet on Tuesday and they don't feel any better, take the tablet on Wednesday, they don't feel any better, take tablet on Thursday, they still don't feel any better, and they think, oh, this doctor doesn't know what they're talking about, they're giving me this tablet because I'm feeling tired, I don't feel any better 3 days later. I think they've got it wrong. Okay, so the patient needs to know a bit more about it. So I normally say that there's a 7-day reservoir of thyroxine in the blood, so you won't feel better immediately. It'll take at least a week and often 12 to 14 days to feel that things are improving. And it may take up to 3 to 6 months for someone with really profound hypothyroidism to feel completely better, particularly the muscle symptoms and so forth. For most patients, it's absolutely fine if they've missed a dose one day, they're not going to feel any different, and the reservoir tells them that, but it's absolutely fine to double up on the dose the next day. Probably exception for that is people with tachyarrhythmias, and then you need to tell them that they are likely to have dose changes in advanced stage or with the menopause, and that they need to change their doses during pregnancy for the benefit of the baby. Monitoring, well, it used to be a quality outcome framework standard, the QOF standard, a yearly TSH check, but that dropped off the GP tariffs about, I guess, 7 or 8 years ago now. But if patients are on levothyroxine, TSH only monitoring is sufficient for almost all patients. And if you do measure the free T4 as well as TSH, you can often get this minimal elevation in free T4, which is misleading. And I'm going to explain that on the next slide. We aim to keep the TSH towards the lower end of the reference range, but the evidence for that isn't particularly strong. But there are two important exceptions to that. Those are patients with thyroid cancer, particularly patients early on in thyroid cancer treatment with aggressive or advanced tumours. Then we often aim to suppress the TSH to less than 0.1, or sometimes just less than the normal range, less than 0.3. And that's because TSH is a growth factor for thyroid cancer, and that has a definite survival advantage. And then in patients with pituitary disease, of course, the TSH comes from the pituitary, and so it's unreliable. And so you need to request free T4 at least to understand, to be able to make dose adjustments in patients with pituitary disease. But to be honest, all patients with pituitary disease are going to be under some endocrinology follow-up, and the endocrinologists will be quite happy to deal with that thyroid replacement themselves, because there's no doubt about it. It's not very straightforward adjusting people's thyroxine if they've got pituitary disease, because our main marker TSH is not reliable. This is the thing about measuring free T4 in patients who are on levothyroxine. So this is patients' free T4 shown in the red line here over the time of day, and the reference range is 10 to 22 shown there. And the patient takes their medication at 06:30 in the morning, and then you get a blip of the free T4 over the reference range for 3 or 4 hours, and then for the remaining 20 hours of the day, it's within the reference range. But if you decide to measure the patient's blood test at 9:30 in the morning, you'll get this kind of pattern. TSH is plumb normal, but the free T4 is high. And quite a few patients I've seen over the years, their levothyroxine dose has been adjusted downwards because their free T4 is a bit high, despite the fact that TSH is normal. And sure, the free T4 was a bit high for about 2 or 3 hours after their levothyroxine dose. So I would really discourage measuring free T4 in most patients who are on treatment for primary hypothyroidism, because it doesn't help you. The TSH tells you enough in the majority of cases. If the TSH is crazy out of control or suppressed, then it becomes worth measuring. But as a first off test, it's probably more confusion than help. So who to refer to secondary care? Of course, 3% of the whole population is on levothyroxine, and so secondary care can't see everyone. But pregnancy is a really good reason, and even pre-pregnancy, for some people, we'd counsel them to increase the dose immediately they find they're pregnant in the first trimester, either by 25 micrograms a day or double their dose 2 days a week, whichever. For patients with unstable or exacerbated cardiac disease when they're started on thyroxine, that probably needs to be shared care between endocrinology and cardiology, at least until their TSH is normalized. Patients whose symptoms don't improve, you can think about those reasons yourself, but if the patients, have had a decent trial of levothyroxine and they still feel rubbish, secondary care would be happy to get involved. If the TSH is persistently abnormal, there are some biochemical tricks which mean the TSH measurement can be incorrect effectively due to laboratory error, and so if you give a decent dose of levothyroxine and the TSH doesn't change, we'd like to see those patients. Could be the lab has got it wrong. But I've seen quite a lot of this over the years, is people who have read a lot of stuff on the internet and they're basically feeling okay, and they want to discuss what they read on the internet with an endocrinologist. And they come with an inch worth of stuff they've printed off. But really, this isn't a good use of endocrine new patient appointment time, I'm sure you're aware, we're inundated with patients. And we can't possibly debunk the whole internet. This is a common thing for patients. I don't feel well on levothyroxine replacement, and I've just got a few observations about these patients. So first of all, how well do we actually do at getting people's thyroids well controlled once they're on levothyroxine? So this basically shows 8 different studies, 4 of them in the UK, 4 of them from other places in the world, over a 25 or more year or more period. And you can see that irrespective of where the patients are well controlled, between 40 and 60% of patients have poorly controlled TSH when they're taking levothyroxine. And of course, the worst healthcare system in the world, USA, is actually the worst for this. 57% of patients who are on levothyroxine in this US study had thyroid function out of range. In the UK, it can get as good as 37% down there. So why should that be? You know, and this is a really interesting study from Portland, Oregon. They took 138 patients who were on long-term levothyroxine for primary hypothyroidism, and they adjusted their medication. So they either dropped the dose or increased the dose. So they ended up with 4 groups who had an average TSH of nearly 9, or sorry, 9.5. About 4 and about 1.8. So 1.8 would be about the median TSH in the population, and so that was that group had about usual replacement therapy, 1.5 micrograms per kilogram, going down to half that. Sorry. In this group, and at the end of 6 months observation, you'd expect the symptoms in the patient group who had the high TSH 9.5 to be worse, but actually there's absolutely no difference in any of the SF36 quality of life questions, thyroid symptom questions, and this study did about 40 different cognitive and quality of life measures on these patients, and basically there's nothing to show. Okay. At the end of the study, they did something interesting, though. The patients were completely blinded to what they'd been allocated. And so they asked the patients what treatment they were taking. Could you guess, were you on the same as usual, more than usual, or less than usual? And the patients, it's a random guess. The p-value was 0.54. They had no idea what they were taking. But when the patients thought their dose had been increased, they made a guess that their dose had been increased. Of course, they were wrong. But if they thought it had been increased, nearly 70% preferred a higher dose. And when they guessed their study dose was lower, nearly 100% preferred their original dose. So this gives rise to this important conclusion. Altering levothyroxine doses in hypothyroid subjects to vary TSH levels, you know, do fine-tuning, as we'd call it, does not affect quality of life, mood, or cognition. But levothyroxine-treated subjects prefer a perceived higher levothyroxine dose despite any lack of objective benefit. So there's a strong cognitive bias for people liking the idea that they're taking high levels of levothyroxine, even though they can't tell the difference. It's a really important conclusion. So what about T3 replacement? So, you know, I was at the American Thyroid Association in 1999 when this Lithuanian study saying that people felt better on T3 was first reported, and I was excited about it. Lots of people were excited. But then 3 randomized clinical trials, one from Bristol in the UK, one from Australia, and one from the Netherlands, each with more than 100 patients. And the Bristol study had close to 700 patients, could not replicate the benefits. Okay, so this one study shown in the green there, with 3 patients, showed some positive stuff, but then 3 more studies with 900 patients overall showed no benefit. And since then, there have been in total 16 studies. And if this drug had no effect, you'd expect a couple of studies to show some slight benefit, which is what they did, the original study and this Danish study, and a few studies to show some slight negative effects, which is exactly what you see. A couple of studies showed some negative effects of the T3. And sorry, this is all in combination, T3 in combination with levothyroxine. So overall, these studies don't show a benefit for T3 combination therapy. But they do show there's strong placebo effect, even for levothyroxine. So if you take someone's levothyroxine off them, you encapsulate it in a gelatin shell, so they don't know what they're taking, but there's a possibility there's T3 in it. They actually feel better. So this just shows you the levothyroxine data only. General health questionnaire, it starts off at 13 and lower is better for this. 3 months just on their same levothyroxine dose, it's dropped to 11, and that's sustained for up to a year. Do you feel better? 28% felt better at 3 months. 27% still felt better at a year, even though we hadn't changed their treatment at all. And if you look at the combination T4, T3 patients, these results are actually identical. And in the feeling better one, actually, they're slightly worse in the T3 group. Only 26% of people felt better at 3 months, 24 by 12 months. And this is the largest study, the one from Bristol, with 697 patients in. So there's a strong placebo effect. And that means when we do this in clinical practice, we give someone a new thyroid hormone replacement and say, this might make you feel better. Well, sure, they're going to feel better, because even if you just give them their levothyroxine back over encapsulated, they feel better. So this leads to the NICE guidelines from 2019. Christine Bolat led these, and I was on the panel, as was BJ Fidja. Do not routinely offer liothyronine for primary hypothyroidism, because those trials really don't support that it works. So the joint BTA Society for Endocrinology statement was issued, I think, in May or June this year. And we broadly support the idea that there's not much evidence for combined therapy. And NHS England basically took a lot of information from the BTA SFE consensus statement, and they've come out with this saying liothyronine should only be initiated in secondary care by a consultant endocrinologist for treatment of hypothyroidism, and it should only really be prescribed if there's no reasonable alternative intervention for the patients. And the reason is just a lack of evidence when you get into randomized trials. So if T3 was a drug that you were using to treat cancer, and you told the patient, well, there are 16 trials and they don't really show it works, your patient wouldn't take that treatment. And similarly, if this was a new treatment for diabetes or for cardiovascular disease, it would have been in the bin after the second or third trial, because, you know, we really rely on these large randomized trials to tell us what drugs work. And when the trials are negative, it's very difficult to support using the drug. So to summarize, start most people with hypothyroidism on a full weight-related treatment dose, the exceptions being people with heart problems. Do give an information prescription for this lifelong treatment. I think that's really important. Contrary to what most patients and most doctors actually think, small changes in levothyroxine dose don't make much difference in blinded trials. And of course, that's for most patients. And I've seen loads of patients who you treat down the levothyroxine dose and they go, oh, I feel much better. But of course, that's placebo effect again. And when you actually blind people, there's not much difference. Patients prefer what they perceive to be a higher dose of levothyroxine, even though the studies show they can't really tell what they're taking. And then T3, I'm not saying I would never prescribe it, or that some patients don't feel dramatically better on T3. But what I would say is it's all about numbers needed to treat. These are large trials, and they show that for the average patient, when you add T3, there's no effect. And a trial with 700 patients in is difficult to beat, because, you know, even if 5 or 10% of patients felt better, that would have been found in a study of that size. So that's all I'm going to say. I'm going to stop sharing my screen and hand back to Sam.
Thank you very much, Simon. Again, fascinating. I'm absolutely blown away by some of the evidence and the great research that's been done in this area. I'm particularly fascinated by the kind of the cognitive dissonance about, you know, taking more medicine and feeling better. And I can't think of any other examples in healthcare where people want more medicine. I sit in clinic all day and people tell me they want less medicine. And yeah, so I think that's fascinating. But anyway, we've got a few questions in the chat. BJ, have you got one keyed up to kick things off?
Yeah, I could start with, and obviously, I think it's for Simon really. So you have shown how the T3, T4 is not beneficial over the T4, and despite that, why is consensus guideline statement recommending T3 for some people?
Okay, so I think that's a really good question. It's an important one. And I think the bottom line is any doctor who decides they're going to stop treatment on a patient who's feeling well on a treatment is a bit stupid. You know, so that's why the BTA and SFE consensus says if you've got a patient who's feeling well on combination therapy, and there's no obvious harm from that. In other words, they don't have atrial fibrillation, they don't have osteoporosis, any of the things we're concerned about, you should just carry it on. So that's why the guidelines are permissive. I see we got a load of flack recently from some smart doctor in was it Pulse magazine about this apparent paradox. But I think that's the bottom line. Why would you change the treatment on someone who's feeling well?
Okay, I think on the same note, I think there was a question about the aim of these consensus guidelines. Was the aim to reduce the number of T3 prescriptions?
That's a question for me again, is it?
So that could go to, maybe Nicola this time. What is the aim of these consensus guidelines? Why did the BTA work on that?
Well, I suppose the first thing to say is that a consensus guideline is exactly that. It's I suppose a sort of a compromise view between a group of people, and I think it's fair to say that there's a spectrum of views on the people who sort of wrote the guideline, and so likewise there may be a spectrum of opinions as to why we wrote it. I think there's a number of reasons. One is actually that it was an issue that was prevalent and present, that the patient body kind of want to know why are we not prescribing this. We felt that there had been some additional studies since the last guideline, not necessarily that any of them were kind of lending a huge amount of weight to changing what we were doing in terms of prescribing T3 much more widely, but we thought that it was sensible to update the guidance. I think from my point of view, I also saw it as an opportunity to maybe I suppose think a bit more holistically about the person in front of us. I mean, the aim is not to remove prescriptions or sort of reduce choice for people. I think the aim is to give clinicians the tools with which to navigate these conversations with people a little bit better. So for me, when I'm meeting somebody in clinic who feels unwell on levothyroxine, I kind of start off with a few ground rules, and the first thing I say is, I'm not as good as a normally functioning thyroid gland, but I will listen to you and I will do my best, and here is the process. Let's start with, was the diagnosis right? Is there anything else? What are the symptoms that you're getting? And I think that the consensus guideline gives a sort of a framework for that. So I think it's a much more positive document than just let's pull the drug out of people's hands. It's really kind of saying, how can we think holistically about the problem to try and achieve patient well-being? That's but Simon might have a slightly different perspective on why we wrote it.
Okay, no, Simon, do you have?
I think that's exactly right. I think we were still seeing a lot of discontent amongst colleagues as well. I think primary care have been in a difficult position. Secondary care have been in a difficult position. I don't think private practice is behaving very well in this regard, and certainly in our local area, some private practitioners will see a patient won't prescribe them T3 and then say they're discharged, your GP can deal with it. That's not good practice. We just, I thought it was important to, as you say, update and also, just share some of the evidence that we talked about, you've talked about, and I've talked about today, why it's not a panacea being started on T3, because if you read some websites, you would have thought that's true.
Yes, so there's a couple of questions on that exact point. So what should the GPs do if the patient come to them with the private prescription of T3 and wanting that to be prescribed under NHS?
Do you want me to answer that?
Yeah, I think both of you should answer, but starting with you, Simon.
Well, I think if the GP thinks it's reasonable to continue and there's a proven diagnosis of primary hypothyroidism, in other words, the patient's got a couple of readings of TSH over 10, and they feel good on the treatment, then that's fine. But, if the patient's 80 and was feeling tired, that might not be very appropriate for that person to be on T3, because the hazards start to become much more. So I think your choices are refer the patient back to private care, get secondary NHS care involved, or if you think it's a reasonable thing on the basis of what you've seen and the patient's got a good response to T3, then it may be reasonable to continue.
I'd agree with what Simon says, and I'd also just want to add, that principle of doctors of first do no harm. So I think if you look at the TSH and you see that the TSH is within normal limits, I'm much more comfortable. If we see that we're suppressing the TSH, which might suggest that then we're over-treating someone, then there is evidence of potential harms. We'd worry about osteoporosis and atrial fibrillation in the long run. So, yep. How well has the patient responded? How robust was the original diagnosis? And is there any suggestion that we're doing harm? And if we're not doing harm and the patient's well and the robust diagnosis is there, then yep, keep going.
I suppose the difficulty there is, and I think probably my GP colleagues are going to want me to say this, is that we're caught between a rock and a hard place here. In that the patient may be asking for T3. Our prescribing guidelines say don't prescribe it. Your consensus statement quite clearly says the patient must be seen by an NHS endocrinologist, and the lovely protocol that you showed, Nicola, has a very clear testing, trial of treatment and follow-up protocol that may not have been followed by the private endocrinologist. So in a situation where there is lovely guidance that's been written and not followed, and then we in the NHS are left in primary care are left to deal with it, and we have two options. One is to say, no, there is a well-written protocol here and you need to see the endocrinologist, which has been pointed out in the chat, and we all are well aware that can take a long time, or prescribe outside of our professional expertise in this contentious and slightly tricky area. That's not really a question, is it? It's more of a statement. I think it will be useful.
The guidance clearly states that you shouldn't do anything you're uncomfortable with, as either in secondary care or in primary care. And if you don't think it's warranted, you're absolutely within your rights to say, this is at my discretion. And GMC clearly says if you don't think it's the right thing to do, you shouldn't prescribe anything, whoever started it. So, once you continue that prescription, you're effectively taking responsibility for that, and you shouldn't take responsibility for anything that you don't feel is right.
I mean, local pathways are going to vary slightly depending on where you are. In Edinburgh, where I work, there are a couple of endocrinologists who do private practice, but they also work in the NHS. And so we've agreed with our GP colleagues that if somebody prescribes it in their private clinic, but it's the same person who might see them in an NHS clinic, we wouldn't draw a distinction. But if it's a private practitioner somewhere else and we don't have access to the original tests and we're not sure whether the diagnosis was robust, then we would want to look at that. And in terms of dealing with the volume of work, I think probably a lot of clinics across the country have moved towards ways of giving virtual advice. And so quite often if GP colleagues contact me and say, this patient has moved over from America, she was diagnosed, her TPOs were positive, these were her original tests, she's on T3, these are her thyroid functions, are you happy for me to keep prescribing? And I think, well, yes, you've told me the patient's well, you've given me evidence the diagnosis was robust, the TSH is not suppressed at the moment, keep going. So sometimes we can do this virtually to try and reduce waiting times.
Yeah, thanks for that. And I think a lot of places are using that kind of advice and guidance protocol, which is probably a really useful way of doing it. Although often it does end up with primary care taking on more responsibility than our professional expertise would feel comfortable. And we're doing that because the NHS is stretched to help our patients, but it's, difficult. On a slightly more practical note, estrogen, a lot of people will be taking thyroxine when it comes to the menopause and starting HRT. And there's a couple of questions about whether we should proactively titrate their thyroxine dose or whether we should measure it at a certain interval after starting HRT. Do you have any practical advice about starting HRT on people stable on a thyroxine dose?
I don't proactively increase it. I think Simon's idea of an information prescription that tells people these are stages in life when doses may need to be adjusted is a really good idea. I know that people, patients, often worry that clinicians are slaves to the blood results. What I try to explain to patients is that really what the blood tests and the normal values are is outer safety brackets. So if somebody, regardless of whether they've gone onto HRT or not, doesn't feel great on their dose of levothyroxine, and their TSH is towards the upper end of normal and their T4 is towards the lower end of normal, actually it's perfectly reasonable to try increasing the dose. And if they've just gone onto a medication that's estrogen containing that suggests that there might be an underlying mechanism for that, then that seems sensible. But I like Simon's idea of an information prescription. I must admit, I haven't done that formally in the past, but I will be giving consideration to doing that in the future.
I think as well, it's a bit unpredictable because, of course, the amount of increase thyroxine binding globulin you get depends on the hepatic exposure to HRT, to the estrogens, and that will be quite different for someone on a patch or a transdermal prep to an oral prep. You'd expect a much bigger change on an oral prep.
Yeah, thank you for that.
Just on the practical management, there was also couple of questions about TPO antibodies. So what is the value of having TPO antibodies checked in a patient with overt hypothyroidism, how that would change the management, and should we be doing?
So
probably Nicola, yeah.
Yeah, I mean, it may not change the management in somebody with barn door overt hypothyroidism, but it might inform some aspects of what we do. So, for example, somebody might have barn door overt hypothyroidism with a history that's suggestive of a thyroiditis, say a postpartum thyroiditis, and then knowing that the TPOs are positive means that there's a slightly higher risk that the hypothyroidism is going to be permanent. To be honest, I'd still give the patient the option of a trial off treatment after we've had them on levothyroxine for a year. So it's not that it's necessarily going to wed me to a particular path, but I think it informs that discussion with the patient. I think where you've got a fairly borderline set of thyroid function tests that might perhaps be a subclinical hypothyroidism that will revert to normal or a non-thyroidal illness that will go away, having negative TPOs would make me think perhaps this isn't really genuine card-carrying hypothyroidism. Let's keep a bit of an open mind here. And I have had at least 2 patients over the years who've come to me feeling very unwell on levothyroxine, who've always had negative TPOs, and actually that's enabled me to open the discussion with them to say, let's be open-minded here. Perhaps your thyroid function tests are normal. Let's take you off levothyroxine. Your thyroid function tests are still normal. You don't feel any worse. I'm sorry you don't feel any better, but at least now we've ruled out the thyroid as the cause of your symptoms, and let's kind of move on to thinking about what they are. So I guess that's how I use TPOs.
So
And with the
Actually,
other thing with
Simon, I really should have let Simon answer, thinking about it, because I'm just a jobbing endocrinologist, whereas the immunology expert is sitting here.
No, but I do exactly what you do. I think, you know, I don't have anything to add to that answer.
Okay.
I think it's the right answer.
well, I'm conscious that we've just gone past 8 o'clock, so we're probably going to have to wrap things up. But just on the TPOs and the monitoring of subclinical hypothyroidism, oftentimes these will be quite young patients who will have a diagnosis of subclinical hypothyroidism with positive or negative TPOs. If the TPOs are positive, they're more likely to become overt hypothyroidism, as you say. But the current advice is to monitor them manually and ask them to look out for symptoms. If we have several years of normal thyroid function following that, we can stop surely and just ask them to watch out for symptoms rather than proactively burdening them with an annual blood test?
I would say that might be okay, but for a woman, if they're going to get pregnant, you need to be quite alert, because you don't want them going into pregnancy with a raised TSH, because that's got definite adverse obstetric outcomes. Right, BJ?
Yes.
But I would still be thinking about occasional monitoring, you know, maybe not every year, but every 3 years or something.
Thank you. Any other questions jumping out at you, BJ, or shall we wrap things up, do you think? There are a lot more questions in the chat. I'm sorry we haven't got through to everything.
Yeah, I think maybe to sort a short one. So there was a question about what is the role of vitamin or mineral supplements in the management of hypothyroidism. I think so. I suppose probably asking about vitamin D replacement or selenium or iodine. Maybe Nicola. Do you recommend?
I don't. I mean, people often ask me that. You know, selenium clearly has a role in thyroid eye disease, and there's a study to back that up. You know, if your thyroid doesn't work properly because it's been damaged by antibodies, then no amount of iodine is going to make that work better. Taking too much iodine, even with a normal thyroid, can cause abnormalities of thyroid function. So I suppose I would caution against over supplementation. But I don't routinely, and if somebody's got vitamin D deficiency, they've got vitamin D deficiency. And certainly if you live in Scotland, you probably should be on vitamin D replacement all the time anyway, because there's so little sun that we don't make any. And that's really government guidance as well. But Simon, any different thoughts?
Yeah, well, Newcastle's not much better than Scotland for that. But, you know, as part of my routine screening for people who are feeling tired while taking levothyroxine, you know, I'll measure vitamin D, measure ferritin, probably measure B12 as well, just to make sure. You know, I think there's a trial about to be published. I think it was actually released in the recent BTA meeting in Milan last week, showing that selenium doesn't actually make much difference to patients with Hashimoto thyroiditis, a large randomized study, because there are a few small ones suggesting some positive benefits.
I think we could probably talk for a long time about vitamin D and the lack of evidence that it's associated with anything, but particularly. But the fact is, much like the massive 5 to 19% of people who have subclinical hypothyroidism on testing, if you go around testing people for vitamin D, you'll find a massive number of people with low vitamin D, quite frankly, because there's not enough sunshine. But I think before we go down a vitamin D rabbit hole, we should probably wrap up. I think that's been fascinating. And thank you very much. And thank you for those who've asked questions. Sorry we haven't got around to everything. And I'll hand back to Julia to close the session. Thank you.
Thank you very much, Sam, and thank you to the to BJ and to Simon and Nicola for excellent talks. It's so helpful for I'm sure they'll be helpful for GPs, but also to the many patients who are listening to. I'm really pleased, Simon, to hear that your recommendation about information prescription. We continue to hear from many patients who tell us that they're started on levothyroxine and other thyroid medications too, T3 and antithyroid drugs, and they're given no guidance or signposting when they're diagnosed, and it's really worrying to them and not helpful to their ongoing management if they don't understand the diagnosis in the first place. So the BT, we know doctors are very busy. If you can signpost your patients to the BTF or other patient organizations when they're diagnosed, we can provide them information, so peer support, which, you know, in many cases will help them. So we're really grateful to the speakers and to the chairs who gave up the time tonight. We know you're all very busy people, and we really appreciate your taking part in the meeting. And a huge thank you to all the people who joined the webinar, the patients and the GPs, of course. A feedback form will be sent out to all of you, and there'll be a certificate of attendance available to any of you who'd like one. And just a reminder, the BTF is a small charity and we rely on fundraising and donations to continue our work. So if you'd like to support us in any way and enable us to continue to provide free events like this, please do consider making a donation or to join us. So once again, thank you very much. Good night, and we look forward to seeing you at future events. Thank you.
Yeah.